Welcome to AETCM, the emergency medicine channel. Today we will be discussing about a difficult airway case which presented to our ER, sir.
Okay.
A 66-year-old male patient was brought to our ER with complaints of drowsiness since last 2 days. Initial 10-second assessment, patient was drowsy but arousable and he was able to answer in one full sentence with a normal sound. Primary survey, patient's airway was patent with no pooling of secretion or hoarseness and neck movements were normal. Breathing, his respiratory rate was 18 per minute with a saturation of 96% in room air and air entry was bilaterally equal with no added sounds.
Okay.
Circulation, his heart rate was 85 per minute, blood pressure was 150/90 with a map of 110 and all peripheral pulses were felt equally and bilaterally. Disability, his GCS was E3 V5 M6 with a pupil size of 2 mm bilaterally equal reactive. Exposure, his temperature was 98 degree Fahrenheit and GRBS was 164 mg per deciliter and hypothermia was prevented by blanket. Adjuncts, at this point of time airway, breathing, circulation within normal limits, so directly went to the history. So sample history, there is no allergies. Patient is a known case of CLD, child C status, ethanol related, and he last ethanol consumption was 1 month back. He's diabetic on OHAs and insulins, and he's hypertensive on Nebicard and cilnidipine, and he is under evaluation for tremors and under neurology, and he is being suspected to have atypical Parkinsonism features. And he is having a history of CAD, and he is on antiplatelets and atorvastatin, and he is having CKD also.
Basically, what I felt is you don't go in depth into the presenting complaint, history of presenting complaint as such. The drowsiness as such, you don't explain how it is, how it has come, how the onset is, how the duration is, how it's progressing. All these things you'll have to explain in detail.
Yes, sir.
And after that only you'll be jumping into the past history.
Okay.
Otherwise you'll be straight away jumping because you have already preformed the idea that it is some kind of a CLD. The patient is come with hepatic NCOF. The other diagnosis will be out of question. Got it?
Yes.
So history of present complaint should be presented in detail.
Yes,
It need not be necessarily hepatic encephalopathy for all CLD.
yes, sir.
Other possibilities are also there.
Yes, sir. So events was this patient was apparently normal 4 days back. Since last 3 days he had constipation and he was taking some laxatives for that when constipation persisted. Then and for the last 2 days patient was drowsy and his feeds were also reduced. He had associated tremor. He already had this typical Parkinsonism tremors, and that tremors worsened since the last 2 days, and that day morning patient was drowsy and he was not getting up from sleep. And bystanders noticed in between bystanders noticed some worsening of tremor of the left upper limb, but that time there was no loss of consciousness or anything, or any tongue bite or any other abnormal movements noticed, and there was no fall in sensorium. So there is no witness seizure activity as such, and there is no history of melena, hematemesis or reduced urine output or fever history. Systemic examination wise,
Any toxin ingestion, other things?
History wise, there is no suspected sedative intake or recent alcohol intake, sir.
Any head trauma?
No, sir, no trauma. Head to foot examination was within normal limits, sir, and higher mental functions. He was drowsy but arousable. He had flaps, but
Head to foot, what are you expecting in this case?
Head to foot examination, we will be looking looking for any contusions or any fault things we will be looking.
Features of head trauma.
Head trauma we should be checking. Then since he is a CLD, he might be having peripheral signs of CLD features. Will be
Seizure, if it is post-seizure,
post-seizure tongue bite should be checked, sir. In this patient there was
secretions. It's poisoning or whatever. It's okay, poison. Pupils.
So he had flaps, sir. There was no ascites or anything, sir. Systemic examination was mostly within normal limit only, and he already had. So we sent for the lab reports.
Okay, we will stop here and just review the whole thing. Because we have a patient who is labeled as a CLD with what we are calling as Cori tremors.
Tremors, yes.
Okay, right. Is it definitely tremors, or are you entertaining any other differentials at this point? Because you're telling unilateral, one localizing things are there.
Can be focal seizures.
Okay. Anything else? Any eye changes? Anything? Any?
During that event.
What is the posture, tone? Anything? Any other limb involvement? Anything from the history?
Nothing, sir.
Nothing from the history. Okay. And sensorium was intact.
Intact.
Any twitching, fasciculation?
Other than that, twitching fasciculation is not there. During that event, there will be a tremor-like activity, and after that, it subsides.
Spontaneous, and then stopping by itself.
Yes, sir.
Without any medication.
Yes, sir. And this was the history what bystanders told, sir. We haven't witnessed that.
Okay.
Since he was drowsy and all, he was admitted to our HDU for further observation, sir. And in the ICU, after admitting to ICU, patient was...
What are the various causes of drowsiness in emergency department?
Most common cause is hypoglycemia, sir. Then it can be because of some head trauma, IC bleed can be there. Or
broadly divided into surgical causes and medical causes.
Medical causes can be hyponatremia, hypoglycemia, hyponatremia can be there. Metabolic encephalopathy, septic encephalopathy can be there.
Poisoning, toxicological causes. Then dementia, dementia worsening.
Long-standing
disorders worsening.
Stroke.
Surgical causes can be acute IC bleed can be there, sir.
Intracranial bleed causing cerebral edema and then decreased sensory. Then there is some tumor or intracranial space occurring lesion with cerebral edema. What all poisons will cause drowsiness?
Sedatives, benzodiazepine.
Sedative toxidromes. All these things. Okay.
Strychnine.
Okay.
Examination, was there any rigidity or anything?
No, sir.
No rigidity. Reflexes?
Reflexes were bilaterally intact, sir. 2+.
Okay.
What will happen in NMS?
There will be rigidity with hyperpyrexia and altered sensory.
Altered sensory. But both rigidity and wasn't
altered sensory was not there, sir. He was having full sensorium and he was admitted to the HDU area. In the HDU, what happened was patient had a agitation like an event. A patient was irritable and he was anxious and he was calling for his son, and that time he had a tonic movement of the left upper limb. Tonic clonic movement was there, which progressed to all 4 limbs, and he had associated tongue bite and frothing from mouth, and it lasted for 2 minutes, sir, and spontaneously stopped. During that, after that event, patient because he was not able to maintain his airway, there was excess pooling of secretions, so we started him, we placed him in left lateral position, and we gave an O2
How
mask.
long the episode lasted?
2 minutes.
No or nothing.
Just before that event, patient was agitated and calling for his son. That might be the event before the seizure, and then the seizure event happened, and this patient was started on O2, placed in left lateral position, and suctioning was done.
Any pharmacological intervention done at that point for seizures?
We have loaded lorazepam, sir, but we didn't administer into the patient. By that time, the seizure event stopped.
What is the dose of lorazepam?
Lorazepam we can give 0.1 mg per kg.
What was the sugar level that time?
That time sugar was 229. So
And was it lorazepam was it given after termination of seizure or like during?
before administering itself, the seizure even stopped. The seizure stopped, terminated by itself.
So you didn't proceed to give benzos?
No, sir.
Okay.
Oral suctioning was done,
Okay.
and even after that there was some gurgling sound, so a nasal airway was placed, sir, and we have loaded him with 1 gram levetiracetam was given, sir. And on
Why
What
levetiracetam?
indications for nasal airway?
indication of nasal airway is in case of any tongue fault or snoring, and if at all this patient is not able to maintain the airway because of an upper airway issue, we will be giving nasal.
Why was oral airway not chosen here?
Gag reflexes
Because of gag
impact.
reflex.
Why did you prefer levetiracetam?
Because this patient is having liver issues are there, sir. So, CLD patient, so it is more safe.
Okay.
When we reassessed the patient, there was secretions was still persisting, frothing was there, and his respiratory rate was 10 per minute, and he was only able to maintain a saturation of 86% with face mask. So we changed it to an NRBM with 15 liter O2, but still he was not able to maintain the airway. So we planned for an RSI for this patient, sir. And when we auscultated also, there was bilateral crepitations. Maybe he aspirated.
But probably he could be in that
Post-ictal state.
So why did you opt for intubation at that point of time?
Because there was persistence of secretion, and desaturation was also there, and we were not he was not able to maintain the airway. That's it.
So probably looking back, the initial tremors itself could have been some kind of early
Seizure.
warning. And do we have a blood gas at any point?
Yes, sir.
Before seizures?
Before seizures, we had a blood gas. Basic blood gas was done before admitting to ICU. That time his ABG was showing a pH of 7.38, PCO2 of 40.8, bicarbonate of 24.8, and lactate of 0.5.
Other electrolytes from lab?
Electrolytes wise, sodium was 135.2, potassium was 3.4 for this patient, and other magnesium was 2, sir, and lab ammonia, arterial ammonia was 140.
Okay.
Other CBC CRP was within normal limits, sir.
Relevance of ammonia?
Ammonia, more than 40 ammonia suggests hyperammonemia, but maybe since this patient is having CLD, ammonia elevation may be because of that, and that might be the cause of encephalopathy and drowsiness for this patient. Even in seizures, ammonia can be elevated.
Okay.
Since this patient had frothiness from mouth and some tongue bite and oral bleeding and desaturation, we planned for an RSI after getting consent from the bystanders. Before RSI, we just looked into the patient. He was having he's an aged person, advanced age, and he's having beard, and he's obese also. So in the look wise also, we are anticipating a difficult airway for this patient, and 332 rule for evaluation was done, sir. We couldn't open the mouth. Since this patient is having secretion, he was not able to open the mouth and evaluate for that, sir. And Malambati score also couldn't be assessed. And he is obese patient with tooth with adequate dentation and frothing and secretions, and he is having a short neck also, and hypoxia is also there, sir. So we proceeded with our RSI. So preparation part, we have prepared for the
what is this called, that this thing called assessment of
lemon score. Lemon assessment was done.
pre-anesthesia evaluation, what is that thing that is called?
Malambati score.
And during intubation,
Cormac grading will be done. So in the bag and mask, for 7 P's of intubation. So for preparation, we have to prepare for the oxygen delivery devices should be given. Bag and mask should be kept ready. Then the drugs for intubation should be labeled and be ready, and the instruments should be ready, and the patient should be connected with the cardiac monitors with 2 IV lines should be secured, sir.
How do you select the blade? Laryngoscope.
Laryngoscope blade, usually adults, it will be we will be using a Macintosh will be used, sir. 4 and 5 will be used, sir. Mostly 4 will be used.
What other blades you know? Other named blades?
Miller blade is there.
Miller is
That
for-
is a straight blade, mostly used in children, but all sizes are there, sir.
What all sizes it's available? Miller blade.
Miller blade 00 from 00 to 5 is available.
What other blade? There's something called McCoy.
Yes, sir.
McCoy blade. No, about it.
McCoy. The
Flexible tip.
tip is there.
one. McCoy blade. For easy lifting of epiglottis.
Epiglottis. Then pre-oxygenation was done with NRBM and bag and since he was not able to maintain airway with NRBM, bag and mask was done, sir. In the during bag and mask also.
How will you do a proper bag and mask ventilation?
Ideally, there should be a mask, a bag, and a reservoir should be connected, and it should be connected to O2 with 15 liter O2, and one person should be doing the setting the mask seal. So we will be using the EC technique will be used, and other person, there should be another person assigned for doing the bagging, sir. So we will be bagging with one hand, 1/3 of the bag will be bagged, sir.
Synchronous with the breath of
Sir.
the patient.
Okay.
So
How many breaths you give normally?
I
6 seconds. 1 in 6 seconds.
before RSA at
Before
least
RSA.
before RSA at least 6 to 8. Ideally 6 should be given, sir, for 3 minutes ideally. So in the mask seal also there was a problem. So there was a difficulty in mask seal. That is, this patient is having a obesity, multiple secretions were there. Then facial hair is there. So these are the difficulty in doing masking for this patient, sir. Then preparation was done with drugs were kept ready. Then pre-oxygenation was done by bag and mask. So 8 bagging was done, and for pre-treatment we taken fentanyl, sir. Fentanyl 3 microgram per kg was taken, sir. And for paralysis, we opted for etomidate and rocuronium. Etomidate 0.3 mg per kg and rocuronium 1 mg per kg.
Etomidate is not for paralysis, no? What's
So,
the
induction agent, and paralysis rocuronium was taken.
what are the other agents which you can use?
We can instead of etomidate we can use propofol, sir. Propofol is having an anti-epileptic property also, but it can cause hypotension. So propofol can be used, etomidate can be used, or ketamine can be used, sir.
But in this case, it's you don't know whether it's.
We don't know whether he is having a bleed or not.
Yeah,
So
ketamine is-
ketamine we cannot use, sir.
Anything one more? Midazolam.
Midazolam, yeah.
Okay. Among the paralytic agents, what are the commonly used for RSA?
We can use depolarizing and non-depolarizing agent can be used, sir. So non-depolarizing rocuronium can be used, or cisatracurium can be used. Then depolarizing agent succinylcholine can be used, 1.5 mg per kg can be used.
Fine.
Since this patient was given with rocuronium, so we have to wait for 60 seconds before proceeding with RSA, so that the medicine can act.
How did you give the drugs? One after the other, or everything together, or what was the time period between the drugs?
In rapid sequence intubation, we will be giving the induction agent and paralytic agent simultaneously, sir.
Okay.
Etomidate was given, followed by rocuronium was given.
Okay, one after the other immediately.
One after the other.
Fine.
So after waiting for 60 seconds, within that
What all
time
monitoring did you have at that point?
we have to we have to secure 2 large bore IV cannulas. Oxygen should be kept ready. Then the cardiac monitors should be connected, and saturation probe should be connected, sir. And suction also should be kept ready. And
What-
ETCO2 also.
Okay, ETC to backup you had. BP, how frequently you are going to monitor? If you have did you have an invasive line?
No, sir. That
Okay, then what are you supposed to do if you're having an ABP?
manual BP should be checked, sir. Every 5 to 10 minutes.
No, at least 1 to 2 minutes you have to set the NABP frequency. Okay, because anything more than 5 minutes you're going to miss the opportunity to intervene. So if you're having an arterial line, that's the best thing. Otherwise, you have to set it at least 1 to 2 minutes of frequency of monitoring. Okay.
So we have positioned the patient in head extension and neck flexion position, and we have for the placement of the tube.
What position?
Sniffing the morning air position, sir.
Okay.
So head extension and neck flexion.
Okay.
After keeping the bed flat, sir.
Mm-hmm.
Uh,
Did you have? I mean, what from history? When was the last feeds?
From history wise, feeds was not known for the bystanders.
Okay.
Yeah, sir. But in an RSA, we should consider all the patients as a full stomach patient.
Okay. Did you have a Riles tube in situ before?
No.
No. Okay.
Since this patient had some already, he's an advanced age person with the obese patient, short neck, we are anticipating a difficult airway for this patient, sir. So since we were forced to act, that means this patient had obvious hypoxia and all, we proceeded with an RSA, and during RSA
What all equipments will you keep ready for difficult intubation? What all things will be?
Along with the different size blades should be kept ready, sir, and the tubes also, the one size, the tube size, which is, I mean, this patient we selected an 8 size tube, so we should keep a 7.5 size tube also ready, sir. Then we have a facility for video laryngoscopy, so that also should be kept ready, sir. And buji also should be there. Suction.
Surgical crike.
LMA, extraglottic devices, and the surgical
Supraglottic.
supraglottic devices and the surgical airway.
Okay.
So during when we did the laryngoscopy, that time he's having a cormac line grade 4. That means even the epiglottis couldn't be visualized properly. So in the grade 1, we will be able to visualize the vocal cords and arytenoids completely. In grade 2, we will be able to see grade 2 we can divide to 2A and 2B. In 2A, we will be able to see the some part of the vocal cords and arytenoid, and 2B we will be able to see only the arytenoids, and in grade 3 we will be able to see epiglottis, and grade 4 we will not be able to see even the epiglottis. So for this patient, RSA was attempted, and it was showing a grade 4, sir. So intubation was attempted thrice.
Okay.
And
any manipulation, anything was done from externally?
Celix maneuver was actually
Have
Celix
So this is for what?
for the esophagus, to compress the esophagus. Burp means we are for adequate visualization we will be doing, sir. We will be pushing the larynx from outside, manipulating it upwards towards right and posteriorly we will be giving, sir.
And Celix is for?
Celix is to compress the esophagus, sir, but ideally we are not supposed to do that, because sometimes esophagus will be right side, and even though when we do our visualization will be affected, so burp should be done. So burp was done, and we attempted thrice, and the third attempt we were able to secure the ET tubes, sir, in position.
With the buji or straight away?
With the buji,
What if you are not able to place?
If we are not able to place ET tube, then we have to go for the difficult airway algorithm. In that, we will be already, if we are anticipating a difficult airway, we should call for assistance. And if we are forced to act, we will be we will be intubating with the normal intubation. We will be proceeding. Then, still, if it is difficult, then we have to plan on supraglottic airways. So, LMAs can be used. Different type of LMAs can be used.
What are the different types of
We have the LMA or the iGel. iGel is there, and LMA ProSeal is there. In that Riles tube also can be inserted simultaneously. Then other tubes like Combi tube, Skim LT is there, and LMA Fast Track is there. Intubating LMA. So supraglottic devices should be kept ready. If that is not possible, then we will have to if intubation is not possible, we will be trying for bag and mask. If that is also failed, then we will have to go for the supraglottic airways. Then after supraglottic airways, we will have to if we are planning to secure a definitive airway, we should intubate with a double setup. That means with the surgical cricothyrotomy, that set also should be ready. Then or we can try for an awake techniques can be tried, sir. Then next part of the algorithm is the surgical cricothyrotomy, or before that we can needle cric can be done, sir. Or we can proceed with a video laryngoscopy, or flexible endoscopy can be done, or blind nasotracheal intubation can be done, and intubating LMA also can be used.
But the key thing there is that once you go into the RSI route, then your awake intubation, everything is out. Okay, so the decision whether to go into the rapid sequence intubation or not needs to be made. Upfront, if you are going for awake intubation, you can use the ramp technique and go for a flexible laryngoscopy and see whether you can place the tube with a flexible flexible laryngoscopy itself. Okay, right. Is there any real advantage between a conventional laryngoscope and a video laryngoscope? Between one among the other? Is one superior over the other, or is both same, or is there a recommended way of using one first, if not the next?
Ideally, we should direct laryngoscopy is mostly used, sir.
Okay.
And in difficult airways, we will use.
Not really. There is not much evidence to say that if you are not able to intubate with a direct laryngoscopy, you can go for a difficult laryngoscopy. There is no proven benefit, but yes, depending upon the expertise, individual expertise, if somebody is very much used to a video laryngoscope, it can be used. It has some edge, but there is no RCTs to prove that one is superior over the other. Again, once you are using video laryngoscopes, there are two types. What are the two types of video laryngoscopes?
Different types are the MAC type is there.
There are a lot of design types. There is a lot, but the basic thing which I was trying to convey is that you have a channeled one and you have the unchanneled one. So unchanneled one, you view and you place the tube after that. The channeled one has, you have to make sure that you have to keep the tube ET tube channel loaded into it. So if you try to intubate with a channeled one from outside, it won't be possible. So identify that upfront. Okay. Fine. Then once you're moving to cricothyrotomy, how will you proceed?
We have the needle cric is there, and surgical.
It's a cannula. Okay.
With the cannula or surgical cricothyrotomy is there. We should for in this procedure we will have to identify the structure. That means first the thyroid cartilage is there, then the cricoid cartilage is there. First we have to stabilize the trachea with one hand. In the other hand, with the other hand we have to palpate for the cricothyroid membrane. And in needle cricothyrotomy, we will be inserting the needle. Needles can also be in different types. It can be a channeled one or the
usually
other.
You can use a 14 gauge
cannula will be used. Before that itself, we have to arrange for the things, sir, because we will be oxygenating either with a 3-way or with a syringe, or we will be doing this. So either a 3-way should be ready, or a syringe, that means a 5cc syringe with a hole, so that we can allow for expiration. These all things should be kept ready. And while introducing the needle will be introduced in a 30-degree angle,
45 degrees.
45-degree caudally. It will be and we will be attaching a syringe with some normal saline loaded in that, and we will be aspirating when
You
we
have 5 ml of NS in it. Okay.
so
Once you see the bubble.
once we see the bubble, we can confirm that we are in the air trachea.
Okay.
Then after that we will be
Introducing the needle, guide wire.
Introducing the guide wire, and we can dilate the
At that point, you can use a blade also if need be. Okay. Fine. You can put a horizontal incision, then you dilate and put in the cannula. Fine.
Or if needle only we are not able to dilate, and if we don't have that facility, then we can directly connect to the syringe we have already, syringe we have already prepared with the hole. We can connect it to the needle, and we will have to occlude that for 1 second and open for 3 seconds for oxygenation.
Yeah. Emergency, otherwise you can go for using a blade and finger technique. You can dilate and put in the small size CT tube itself if the facility is not there.
So how long we can keep this thing needle quick?
A maximum 30 to 45 minutes, sir. Within that time, we will have to go for a definitive airway by a tracheostomy or surgical.
Okay. Any thoughts about retrograde intubation?
Retrograde intubation will be usually done with a guide wire, sir. We will be usually when we are doing for needle cricothyrotomy, we will be inserting the needle caudally. In this case, we will have to insert the needle cephaloid, and then we will have to after confirming the position the trachea, we will insert the guide wire into it, and it will be coming out through the mouth, and then through that we will be loading the endotracheal tube inside. The Murphy's eye of the endotracheal tube should be locked with the guide wire strip.
If you're planning to write the MRCM exam, you follow that DAS algorithm, Difficult Airway Society algorithm. Because American Society of Anesthesiology, they have got also separate thing. But for MRCM purpose, always follow the DAS algorithm.
Anything else? Okay.